We'll wait a few moments anyways, because it'll take a little while for everything to populate. Here they come. Welcome, everyone. We're just letting all the attendees populate. They're all coming in. So we thank you for your patience. Okay. Here they come. Let's go get started then. Wonderful. Good afternoon and welcome to the third session of the Brain Injury Association of Rhode Island's 20th Annual Conference Series. My name is Doreen Grasso and I'm the Education and Program Manager here at BRE. We're delighted that you can join us this afternoon for a multimodal approach to management of acute concussions. Before we get started, we would like to acknowledge our conference sponsors. Thank you to Encompass Health, Evan Lee Organics, and Marasco and Nesselbush Law Offices. Now, here is our Executive Director, Deborah Sharp, with a few words.
Good afternoon and welcome. As Doreen said, this is our 20th anniversary of holding conferences focused on improving knowledge and awareness of brain injury and the consequences of brain injury on our society. Like most organizations, the pandemic has changed the way we are doing our business. Normally, we have an in-person full-day conference annually. However, this year we've gone to a new format with these virtual conferences. And as you know, there is a series of 6 webinars we're offering. So in a sense, we're learning new technology, learning new ways of connecting with people. And one of the best parts of this format is that it gives us an opportunity to engage folks from all over the country in our work. So thank you so much for being here and supporting us. Be sure to check out the website, biari.org, to explore other webinars that are coming up. Take the time, there's all kinds of information on the website about how we accomplish our mission, which is to provide education to help prevent brain injuries, as well as enhancing the quality of life for those affected by brain injuries. So thank you so much for your support. Looking forward to a really interesting webinar this afternoon. And now it's my pleasure to introduce to you Daniel Parkinson. Daniel Parkinson is the Business Development Manager of Encompass Health, which is our platinum sponsor for this year's conference series. So please join me in welcoming Daniel. Dan?
Hello, my name is Dan Parkinson, and I work at Encompass Health Rehabilitation Hospital in Braintree, also known as Braintree Rehab. We're an inpatient acute rehabilitation hospital, and we've earned the disease-specific certifications in both brain injury and stroke rehab from the Joint Commission. This means that we have a programmatic approach to our delivery of care that allows us to realize the strongest patient outcomes. The essential components of our program consist of using evidence-based, consensus-driven clinical practice guidelines to drive our interventions and our assessments. We have a multidisciplinary team that's led by Dr. Katz, a neurologist, and our team consists of physical therapists, occupational therapists, speech therapists, nurses who are certified in rehabilitation, and case managers. We implement performance improvement measures that are related to our clinical practice guidelines to help us drive our patient outcomes. We analyze our patient outcomes by both trending our own data over time and by comparing our data to other rehab hospitals both in the region and throughout the country. I really want to take this opportunity to thank the Rhode Island Brain Injury Association for hosting this incredible virtual learning experience and for giving us here at Encompass Health Rehabilitation Hospital of Braintree the opportunity to introduce ourselves. Thank you and enjoy the educational opportunity.
Thank you, Dan from Encompass. A few housekeeping notes before we start. All participants have been sent an evaluation form. Your feedback is very important to us so we can best serve you, but it's also your ticket to your CEUs if you are choosing to receive CEUs for this. The evaluation form, once it's completed in full, can be sent to richard@biari.org. It's also on your evaluation sheet, and you'll get your CEU certificate in approximately a week at max. Participants who signed up for the entire series will get their CEUs in October once all the series is complete. Lastly, please type any comments or questions that you have in the chat room. We have reserved some time for Q&A at the end of the presentation. So thank you for helping with that. Now I'd like to introduce our speakers for today for a multimodal approach to the management of acute concussions. John Garlick is a board-certified orthopedic clinical specialist and has been part of PAPA's physical and hand therapy since 2013. He has a BS in movement science with a concentration in sports medicine and earned his doctorate in physical therapy at URI. He completed an evidence in motion residency in orthopedic manual therapy and is a certified vestibular rehabilitation specialist through the American Institute of Balance. John was certified in 2018 in acute and chronic concussion management through Complete Concussion Management. He now assists in managing concussions from the acute phase and facilitates patients back to work and/or activities in a safe and timely manner. Dr. Amity Rubeor is in private practice at Family Health and Sports Medicine in Cranston. She is a board-certified family physician and sports medicine physician. Outside the office, she is a team physician for the PC Women's Ice Hockey and an assistant professor in the Department of Family Medicine at Brown University, and on the board of directors for Special Olympics Rhode Island. She has been involved in concussion management and education for over 15 years. Welcomes Drs. Garlick and Dr. Rubeor.
Thank you.
Thank you very much. I can get started. If John, you're able to share the PowerPoint, that would be awesome. All right, perfect. Okay, well, thank you guys so much for allowing us to do this presentation. Yep, John, you can go right ahead to the next slide. So John and I came up with this presentation essentially to help you meet the objectives that we have listed here in front of you. And this was also in the description of the presentation. We really want to make sure that you feel comfortable with a standard approach to managing concussions, and also help people identify concussions early so that they can intervene early. We'll talk a little bit about the team approach, and that team involves, of course, the athlete's family, school personnel, and allied health professionals. And then we're going to try to essentially help everybody be able to get that athlete or injured student back in a timely and in a safe prior level of function. So John, if you want to go ahead again. So I put this slide up here not to help you guys. I don't want people to think that I'm obsolete, but as I started to prepare this presentation, I realized that the first International Concussion Conference in Sport was done in Vienna in 2001. And I realized that that was 20 years ago. And so there might be some people here who don't understand how revolutionary that conference was, but it really was. That first conference in 2001 was the very first time that we decided to stop grading concussions. Years ago, we would go ahead and we would advise that people, we would be giving grades on concussions based upon loss of consciousness. And so at that time, we probably were not managing the concussions to the best way that we possibly could. We told people that athletes needed to be woken up every few minutes in the middle of the night when they had a concussion, really not focusing on allowing an athlete to sleep. And so 20 years ago, we really started to make this change. And that was the first time that we stopped grading concussions right away. And that was the first time that we introduced this concept of return to play. So John, if you want to go ahead and go again. And so that's what we're going to talk a lot about today, is we're going to talk about how we need to think differently, how we need to individualize our treatments for concussions, and we need to allow an athlete to safely return to learn and safely return to play. So I'm going to start with a case because I feel like it's always great to start with a case. And we're going to start with an old case, maybe how things might have been managed years ago. And again, I'm old enough to actually remember when this was exactly what would have been done. So this is a 14-year-old freshman girls soccer goalie who is going to save a ball, and she hits her head on the post. She struggles to get back up to her feet, but she can actually effectively return the ball. And so they let her keep playing. And at halftime, the coach asks her, "Hey, can you keep playing?" And of course, she's thinking, well, yeah, I want to keep playing. This is my sport and I want to be involved in the game. So she keeps playing. At the end of the game, she's a little tired. She tells her parents, "Yeah, I got my bell rung on that, when I hit my head, but I'm okay." She goes to school the next day, but she's tired and she can't focus. She talks back to her teacher and she's sent to the principal. She's eventually allowed to go to practice that afternoon, but she's not playing well. She hits her head again. She loses consciousness, is poor to respond, and is rushed to the hospital. Now, that's a very dramatic presentation. And essentially what I'm describing for you is a case of second impact syndrome, where she sustained a concussion with that first hit in the game, and she had not completely returned to her prior level of function when she got hit again. And with that second concussion that she sustained, she developed massive swelling in her brain, which was cutting off fresh blood to her brain, leading to this second impact syndrome, a life-threatening, severe diagnosis. So how do we avoid having an athlete even get to that situation? Next slide, John. Yeah, so there were so many people along this path that could have stopped and gotten this athlete out of the game and into the proper hands to help her recover. Nowadays, when a referee recognizes that something is considered potentially a head injury, they're stopped and an athlete is asked to be removed from the game. And certainly if the referee doesn't recognize it, it's really that coach's responsibility to then go ahead and remove that athlete from the game. The coach should notify the family and not leave it up to the athlete. And hopefully maybe even at school, potentially somebody would have noticed, somebody at home, somebody at school would have helped this athlete have a better understanding of what was going on with them. So let's move on to case number 2, our next slide, in which case this kind of epitomizes a more optimal management plan. She hits her head. The coach immediately pulls this athlete from the game. The coach talks with the family, who talks to their primary care physician. And fortunately, this player is able to be seen in the office later on that day. And so in the office later on that day, a referral is immediately made to physical therapy, knowing that, after a few days of rest, as we're trying to get this athlete back into her game, we're really going to use some other allied health professionals to help her get there. The athlete stays home from school, but the family and maybe even the doctor have spoken to the school nurse, and a gradual return to learn program is put into place for this athlete. And then she completes her return to play protocol that's led by her physical therapist or her certified athletic trainer if she has one at school, and she safely returns to her sport. So we've essentially seen in this case an opportunity to avoid some sort of tragedy like second impact syndrome. And that really is what Karen McAvoy had in mind when she developed the REAP manual. If you want to go to that slide, John. And so in 2004, Dr. McAvoy, experienced a situation similar to that first case. And we were able to, in fact, see the unfortunate outcomes of a second impact syndrome. She realized that a standard approach to concussion management needed to be put in place, and the team really needed to be involved. And they came up with this great mnemonic, the REAP manual, essentially meaning that our goal is to remove an athlete, a student, anybody from the situation and reduce any sort of factors that could be contributing to their poor recovery. Everybody needs to be educated as to what is going on with a concussion, and that might involve adjusting and accommodating levels of activity, whether that activity is at home, whether it's at school, wherever it may be. And we just help people understand that we need to pace and slow down our recovery. Okay, so you can move on to the next slide, John. All righty, so let's talk a little bit more about this team approach. I love this slide because the colors at the bottom remind me of the Braslow tape that, when we're in the emergency room, how to know how to treat a certain aged child based upon their length. I look at this and I go, oh, immediately I know that if I'm part of the family team, I need to look at the portions of the REAP manual that are in orange, or if I'm part of the school as a principal or potentially as a school teacher, then I need to look at this dark blue. Now, it is divided in this REAP manual for family, school team, both physical, meaning coaches, school nurses, certified athletic trainers, and school team academic, and then as well as the medical team. We're going to focus today, John, you can switch to the next slide, primarily on our school team, since many of us who are attending this webinar are involved in this way, whether you are a school nurse, whether you are a teacher, a school psychologist, or a school social worker. And this might be very familiar to all of you. You might be very familiar with the REAP manual. I'm just hoping that we can go ahead and just expand a little bit about it, expand onward as far as concussions go, and open up some discussion on other ways that we can help manage our athletes and our students' recovery. All right, you can move on to the next one. So I actually I titled this one Recognize, and I underlined and bolded the R because just like in the REAP manual, we're talking about removing and reducing. I feel like recognizing and understanding what a concussion is very important as well. Now, sometimes it's obvious, getting a blow to the head or having your head hit an immovable object. It makes a lot of sense that somebody might get a concussion from those situations. But like the picture on the far right says, it doesn't take a head-on collision for somebody to develop a concussion. And so all the little yellow triangles show at the bottom, it could be a fall onto your bottom. It could be a slip down the stairs. It could be any sort of torquing motion that then leads somebody to and within the functioning of the brain, which is what we're going to talk about a bit, leading to the symptoms that you see here on this slide, and then the next slide, John. This next slide really divides up symptoms of concussion in a very easy way to remember. When Halstead published this in 2010, it was innovative. It was great to see them divide up into these 4 categories. And now when you look at any literature on concussions, it often is divided up into these 4 categories. So yes, sometimes it's really easy for us to recognize the physical symptoms, such as headache, balance problems, sensitivity to light, nausea. I think we're now starting to recognize more of those cognitive functions in school. If an athlete is just questions, they're just not getting it, or they're complaining of feeling mentally foggy or slowed down, then that too. That would definitely be an indication of some of these cognitive symptoms of concussion. Irritability, emotional. When I was an athletic trainer in college many years ago, we had a football, normally a very quiet, when he sustained his concussion, he came off and he was the most gregarious, talkative player. I never seen him react so differently. So it doesn't always necessarily mean that they're more irritable or more sad. It could be any form of emotion that becomes more pronounced. And then lastly, because sleep is so important in recovery, we're going to focus a lot on how this is important in recovery, but athletes who are having difficulty falling asleep, staying asleep, are going to be drowsy, complaining of more fatigue when. All right, John, you can go to the next slide. So I have to look about what happens when you have that injury. And I talked about that shearing effect on the brain is eventually lead to a concussion. The REAP manual does a great job of saying, don't refer to a concussion as a bruise to the brain. The analogy they use, which I think were great, is that it's basically an iPhone 4 when you really need an iPhone 10. It's like trying to drive a car with only, a 5-gallon tank of gas, needing to stop and refill repeatedly. And so if you look at this picture on the left, from day -1 to 0, you can see that everything is functioning normal. You've got your yellow, your red, and your blue line, all hunky-dory, 100% normal activity. And then all of a sudden you get concussion. And what happens at that cellular level is the sodium and the potassium pumps and the calcium, all of those things at the cellular level, they are thrown completely off with that shearing effect. And so all of a sudden your body says, hey, we really need to, get things going and repair. And there's this increased demand for glucose or sugar in the yellow. But at the same time, the body just kind of shuts down. And the as you can see from the red line, the brain activity reduces to about 50%. So there's a decreased blood flow with an increased demand for energy and increased demand for glucose. And so as you can see on the far right, you've got all these things happening at once: high energy demand, decreased blood flow, and you get this autonomic mismatch where your brain is kind of slowed down, but your body still needs all that energy to keep going. And it can take days, it can take weeks for this to completely recover. So that's what we're dealing with when we are dealing with a concussion. And that's why people present with the symptoms that we just talked about. They are foggy, they are slowed down because the energy is not there. Just like the REAP manual says, yeah, it's like an iPhone 4 trying to run programs that are made for an iPhone 10. It's just not equivalent. All right, John, you can move to the next slide. So after we have recognized what a concussion is, well, then it's time for us to go ahead and remove that student, that athlete from the situation. And so sometimes it's really easy. It's easy to say, okay, you just can't go back in the game. But, we're trying to help you understand, what if this athlete comes to you 1 day, 2 days later? What else do we need to remove them from? Do we need to remove them from gym, recess, band, chorus, dance? Yes. I have had a number of athletes who played musical instruments, and it was we needed to remove them from band because of the increased energy demand. Your heart rate goes quite high when you are playing the drums, and the amount of pressure through the brain, through the Valsalva maneuver, when you're playing something like the tuba or the trombone, is intense. So we need to remove them from any sort of activity that's going to make their symptoms worse. John, if you want to move on to case 3, our next question. And so here's a great situation. So this is a 12-year-old non-binary student who's presenting to the school nurse with a headache. And so they tell the nurse that they and their mom were involved in a car accident the night before. They didn't go to the hospital. They didn't think really anything of it. But they woke up with a headache this morning, and their neck is really stiff. And frankly, school is really difficult this morning, and the overhead lights are really bright, and their vision is getting blurry. And so in this situation, you're dealing with a student who's presenting to you a day afterwards, who hasn't seen the doctor yet, and who hasn't necessarily even shared these symptoms with their family yet. And so the question is, what is our next step? So you can move on to the next slide, John. And so again, we're going to go ahead and educate, and we're going to help this student understand that they likely are suffering from a concussion, and that these symptoms that they're expressing really correspond to having a concussion. And then go ahead, John, to the next slide. And so ideally, they need to go home. This is a situation where we would be calling the student's parents and letting them know our concerns for concussion, and that it would be great for them to see their primary care physician, to undergo an evaluation, and they should be resting for about 48 hours to maybe 72 hours the most. But no longer do we cocoon people. We rest them, but we don't cocoon. That came out of that 2001 Vienna conference. We had people shut down, and we realized that actually we don't want to shut athletes or students directly down. We don't want them to sit in a dark room for days, but they absolutely can, take a couple of days to rest, but then they need to start increasing their activity. So whereas in the beginning, we limit their activity, we limit their screen time, we limit their homework, we gradually want to increase it after those 48 to 72 hours, as long as their symptoms seem to be slowly improving and not worsening. So John, you can go to the next slide. Excuse me. And so when we talk about screen time, it's really difficult to tell students that they can't have any screen time at all. Nowadays, everything is on a screen time. And so I feel like we used to give an estimate of like, well, why don't you limit your screen time to 2 hours or less a day? But that might work for some people, and it might not work for other people. Other people might notice that they get on their phone for 5 minutes or 10 minutes, they immediately get a headache or their symptoms worsen. Some people might feel like if they are on their computer and they're tolerating it, they can tolerate for 15, 20 minutes without any problems. So you allow the student, you start with a little bit of screen time, and then we just gradually increase the amount of time that they're on it. So on the picture to the right, it talks about phasing in screen time. You start with 5 to 15 minutes, and then you gradually increase it as long as it's not worsening their symptoms. And sleep. Sleep is so important, helping the student's family realize how important sleep is by, trying to make sure that there's a consistent bedtime, a consistent wake time, really trying to limit electronics immediately before bed, optimizing sleep hygiene, make sure the room is cool and dark and relaxing, and just, again, allowing your brain to recover. That's what we're going to do during this recovery time. Is the brain, that's when it's going to rest. That's when it's going to get the time that it needs to really improve. And then, like I had talked about, next slide, thank you, John. When we talk to that family, we get that student home and we advise them to rest in those first couple of days to get that in, see somebody, whether it is their primary care physician or whether it's immediately to somebody like John, who can evaluate the concussion as well as I can, and start talking about, getting them on the road to recovery. But the benefit of having them seen by a health professional is obviously we're going to do a more comprehensive exam and make sure that there's nothing more serious besides a concussion going on. So we want to do a full comprehensive neurologic exam. And we want to get a history. We need to know, have they had concussions previously? Do they have any other learning issues or attendance issues, or mood issues? We want to recognize anything that could potentially interfere with that student or that athlete's recovery. So we'll have that student or athlete see their healthcare professional. We're having them on that 8 to maybe 72 hours of rest. And then we're saying, okay, let's get this athlete back to school, because we don't want to cocoon them. We want to get them back into a normal system. So John, if you want to go to our next slide. I took this picture from the REAP manual as well, because I thought it was very helpful in helping us understand how we can adjust for the student in school, or perhaps even accommodate. So in general, athletes can begin a return to learn when they're able to tolerate about 30 to 45 minutes of light mental activity. And so if they're home and they're able to do a little bit of light mental activity, maybe, 30 minutes of a couple of different, 30 minutes spending some time on each class, trying a little bit of homework, whether it be on the computer or whether it be pen and paper, then it might make sense for them to come back into school. And then you say, okay, what is the best way for me to get this student back into school and succeed? Well, what if they're really struggling with sleep and energy, like you see down in that bottom right-hand corner of the circle? What if they really are still fatigued, they're drowsy, they're sleeping too much? Well, maybe we need to adjust that student's schedule so that they come in the morning or they come in the afternoon. Maybe we need to figure out that they're not they shouldn't be there for the full day. And I say they, mean they should adjust or accommodate. It could be any member of our team. It could be the suggestion of the healthcare professional. It could be the suggestion of the school nurse. It could be the suggestion of the teacher. The idea is that we're all working together to come up with the best return to learn program for that student. Now, what if that student is really struggling with, oh, go back, John. You were you anticipated me. but what if it is more cognitive? What if they're struggling with concentration, remembering, feeling mentally foggy, kind of in that right upper corner of the circle? These are the people that it's great to remove non-essential work, no busy work for them. Or maybe these are the students that would benefit from teacher notes or notes. If they're having more physical symptoms in that top left-hand corner, maybe these are the students that would benefit from sunglasses or more breaks throughout the day. And then lastly, the students that might be more emotional, they might need like a signal. They might need to have a signal with their teacher to say, when they start to feel more overwhelmed or anxious, that it allows them to take that break. The other thing that I really liked about the REAP manual was the clarification of what's an adjustment and what's an accommodation. And so, because many concussions are going to recover even before we get to the end of 4 weeks, we might not need full-on accommodations in class. We might be able to just do brief adjustments that a teacher and school nurse and school psychologist can work together to come up with a plan. Or maybe we do need something in place a little bit longer. So that the student can safely be able to take their midterms or their finals or complete a major project. You can move on to the next slide, John. And so this is where knowing the athlete's background as a healthcare professional or even as a school nurse or school psychologist helps us adjust their treatment. And so if it is an athlete who actually suffers with some level of anxiety at baseline, well, we know that their concussion actually might make that anxiety a little bit worse. So maybe those hand signals in class and then arrangement with the school psychologist and the teacher to say, when somebody's getting a little too anxious or upset in class, needs to be referred for a session with a school psychologist, that might be perfect. Or if an athlete has a pre-existing condition of migraines, well, then they might have worsening headaches with their concussion, and they might benefit from sunglasses or that need for shortened periods of time. So that's essentially what this slide, and then John, if you want to move on to the next slide, this is a very busy slide and it might be difficult for you to see, but this is essentially saying the same thing in that you need to know what somebody's pre-existing conditions might potentially be and how that might influence somebody's recovery from their concussion. And so many things can overlap. And this publication is actually part of the SCAT forms or sideline concussion assessment forms that are being used by a lot of coaches and certified athletic trainers when they're evaluating an athlete who's sustaining a concussion. So John, if we want to move on to the next slide. This will be my last slide before I turn it over to you, John. Or actually, I've got one more after this, but our last example. So let's talk about somebody who is maybe taking a little bit longer to recover. So this is a 16-year-old male who's presented to the school psychologist distraught about his school performance. He sustained a concussion while playing in a game the week before finals, but he came back to school because he didn't want to get behind. He did early on his finals, but he was given a chance to retake them, but he's still symptomatic daily in school. And right now he's really struggling with how to organize his current workload with studying for his makeup work. And so next slide, John. So as a healthcare provider, it's in these situations that I take a step back and I say, okay, it sounds like we need to advance your therapy. And so hopefully I already have this athlete in physical therapy to help him recover from a lot of his physical symptoms. But maybe at this point, I need to have him involved with, some cognitive behavioral therapy, some therapy outside of school, maybe even a little bit of speech therapy. But certainly this would be a great athlete for me to refer for neuropsychological testing, to then see if I can help use a neuropsychologist and a neuropsychologist working with the school psychologist, school nurse to help get this athlete's work more just to help this athlete get their work under better control, more organized, so that he feels well and feels like he can accomplish what he needs to do. And with that, John, I'm going to turn it over to you and you can share your screen with your presentation.
Thank you. All right, everybody can see that, right? So, yeah, my name is John Garlick, physical therapist, and luckily you get to work down the road from Dr. Rubeor, so we get to kind of co-manage these patients often, which is really, really great. A little about me, I was already introduced, so this stuff is no longer important. Objectives, really understand the role of a physical therapist, because I think to a lot of people this can be kind of news that physical therapists work with patients with concussions, and a lot of even the patients that make their way in here are kind of unsure as what it's going to look like. So get a better understanding of what we do, what role we play, and as well as gain an understanding of, or a better understanding of, return to play and learn guidelines and how we go about making those decisions. So, again, a lot of people, I don't know, you guys treat concussions. Well, we don't, we manage them. So the concussion, Dr. Rubeor's graph that she showed where the glucose requirement goes up and the blood flow is down, that over time you see normalizes. We do want to make sure that there's no second impact syndrome that would affect that graph more, but over time that will normalize and things will get back into balance. So we're not treating that. We are managing and making sure that they are taking the education from that initial visit with their primary care, and they're using that information. They're following the doing the right activities and avoiding the right things. So we're there just to make sure that they are doing the right things initially. So we're not treating. I compare it a lot of times to, somebody breaks their arm. I don't treat their broken arm. We treat the consequences of the broken arm. So same thing here. We don't treat the concussion. We treat the consequences that come after the concussion. This picture I think was perfect. These patients can come in very overwhelmed. They are maybe, ideally I get to see them within the first week. But oftentimes it's not. And so they may have gone through a couple weeks of being out of work. They are forgetting things. They're worried about falling behind on bills, or they're worried about falling behind in school. They're worried because they have a big tournament coming up in a couple weeks for some athletic event, and they want to be able to get back to that. So they have a lot going on, and especially as a young kid, they haven't been able to hang out with their friends maybe, and they maybe were given the information of just staying in the dark room and not doing anything. So they've lost a lot of communication with their friends, and which can be their support system. So initially, we are there to kind of help them manage and get all those things in line, prioritize, and get things moving in the right direction. So our first session with somebody who has sustained a concussion is we call education and reassurance. So we focus on a lot of education, usually, and sometimes we don't want to overeducate with certain musculoskeletal disorders because it can really scare people sometimes. But we use this as a way to actually reassure people. So again, the graph that Dr. Rubeor had in her slide, I draw out that graph with every patient, and we talk about what changes over time and at what points what to expect. And the reason I draw that graph out is because I like to show them that it gets to a point where it does return to normal. And nowadays, a lot of people have concerns about concussions and CTE, and are they ever going to be the same? And they hear about the football players with CTE, and I use it as a way to reassure them that things will return to normal. And as long as we manage this concussion properly, there's no evidence down the road to support that you'd have any issues with CTE. Even repeated concussions, I don't know of any evidence that shows that repeated concussions would lead to CTE as long as they're managed properly each time. So again, we're reassuring them on that type of stuff. We're educating them on what to do and what not to do. We give them that education, the pathophysiology of a concussion. We give them the expectations of what's going to happen, and I get down a couple points there, but the plan, the expectations of what's going to happen over really the next couple weeks. And we do also reinforce the education on sleep hygiene, nutrition for strong brain health. This educational component, the research done on this, by the institution where I got my certification, they've done research specifically on the first visit of education and reassurance. And the outcome measure that they've used, they've had 50% improvements in that outcome measure on the second visit. So people leave this visit feeling much better already. Almost everybody says, oh my God, I already feel so much better, especially, when the parents come in with the young athlete. The parents feel a lot better because they know they have structure. They know what we're going to be doing over the next couple of weeks. And they have the perception that, somebody is helping to manage that, knows what they're talking about. Because if they just go to the ER, then they just get sent home and they don't really have much guidance as to what to do. So that's a real key component, and that is what our first visit is. We talk, answer questions, and that's all we do the first visit. Now, typically, again, this ideally is, hopefully a day or two after the concussion. So really at that point, we would not be doing too much anyway. All of the education stuff that Dr. Rubeor talked about, that 2 to 3 days of rest, that's the same thing I tell everybody, and it's not in a dark room type of rest. It's just not intensive schoolwork and no sports, but do what you normally would do. Help pick up and clean around the house, watch TV, read a book. Maybe go for a really light walk around the neighborhood, and just kind of, as long as no symptoms are worsening, just kind of do what you normally would do. A week after the concussion, we do our first physical exertion test. So these exertion tests really help to determine when it might be appropriate for somebody to return back to sport. So this is kind of the initial test. So as Dr. Rubeor talked about, there's that decreased blood flow. So if we have a decreased blood flow, we're going to have really poor endurance and tolerance to exercise and getting our heart rate up. So we do the Buffalo treadmill test a week after the injury. We monitor heart rate, rating of perceived exertion, and we have a form called the overall condition score, where the patient rates their current status from 0 to 10. And we monitor very closely. So we're there beside them the whole time. The test consists of 2.5 mile per hour warm up for 2 minutes. And then we go to 3.3 miles an hour, which is still a walk. And every minute we increase the incline 1%. It goes up to 15%. And we are there every time we bump that percentage up every minute. We ask them where they are on the RPE scale. If their symptoms change at all, we tell them to let us know, and we ask where they are on the OCS scale. And we continue to monitor heart rate to make sure it doesn't reach the point of their max heart rate, their adjusted heart rate. So if any of those things happen, if we reach the age-adjusted max heart rate, RPE gets up to 19 or 20 on a 6 to 20 scale, and if their OCS changes even 1 point, which means their symptoms have increased a little bit, then that's where we stop the test. Also, at any point, if the patient feels like they need to stop, then they stop. They tell us that they have to stop. So what we do from there is, if they pass the test, then I tell them, okay, you can go on, maybe longer walks around the neighborhood, some yoga, stretching, light physical activity at home, even, really lightweight training I'd be fine with. No heavy weight training. But the most important part there is no contact sports. So no real practicing drills, like sport-specific drills, and definitely no practice with anybody else, because that can tend to get a little intense. And even though you don't plan on getting hit in the head, you may do that by accident again. If they do not pass the Buffalo treadmill test, then we prescribe an exercise plan, which consists of walking at 80% of the point which they failed. So we take their heart rate, say they get up to 150 beats per minute, we take 80% of that, and we tell them to start walking, and tell them 20 to 30 minutes a day at home at that heart rate. And luckily, most people have, Apple Watches, fitness watches now that can tell them their heart rate, so they can utilize that. And then that's all we do that day. Usually in total, it might take about a half hour, but we get some good information out of that test. The next session, they come back, they tell us how they are feeling with their walking program, how they felt after the treadmill test, and we may adjust things from there. And we start to look into the cervical spine. So it's estimated that it takes about 70 to 120 G's of force to sustain a concussion, but it only takes about 4 G's of force to sustain a cervical injury, a sprain or a strain of the cervical spine. So most of the time, pretty much 100% of the time, we expect that these patients will have some type of cervical spine disorder, musculoskeletal disorder that we need to address. So we start to dig into the cervical spine and find what deficits we can there. And the other part is the vestibular system. So in this third session now, we also dig into the vestibular system. We find the deficits there between the cervical spine, the vestibular spine, and we begin to work on those systems. Just like the brain can get damaged during that whiplash type injury or that blunt force injury, the vestibular system can sustain injury as well. And what usually ends up happening is, the vestibular system can give us dizziness. It can give us balance issues. It can make our eyes move in funny ways where we start to feel headaches and nausea. The neck, the cervical spine can give us headaches and cervicogenic dizziness as well. So we start to assume that a lot of these symptoms are really to do with the concussion, but actually a lot of the symptoms are more so due to the damage of the temporary damage of the vestibular system in the neck during the injury. So like we saw in that graph, the brain actually heals and gets back to, a normal balance fairly quickly. So after that, when we have these persistent symptoms, we really need to look at the vestibular system and the cervical spine. So I think that's where physical therapy plays a big role. So these patients can struggle with vertigo. So, the BPPV type of vertigo, where we need to do canal 3 positioning, Epley maneuvers and things like that. Or they can just struggle with issues with their VOR reflexes and balance, with gaze stabilization and smooth pursuit and all that type of stuff that can make them feel dizzy, can make them really uncomfortable with schoolwork and reading the board and following, things like that. So we address that stuff. And then we're starting to think, this whole time about return to learn and play. And I had the same slide as Dr. Rubeor from the REAP manual. It's a great slide. It does require that we have a lot of people on board. It's what I tell patients a lot of times is that, yes, you have to take a little time out of sport. But this is a sacrifice of hopefully 3 to 4 weeks at the most. And if you do really well, then you'll be right back to where you were. If we don't manage this well from the beginning and get everybody involved, then we see patients a year and a half out with continued symptoms of their concussion where they're still not able to get back to work or sport. So if you don't take the time right now and sacrifice this time up front, then you really could stretch things out very, very far. So it takes this whole team approach, and it takes a lot of work to make sure this is being managed properly. So I always encourage, I always try to talk to the medical team as much as we can on our end, and encourage, conversations between the family and their teachers and guidance counselors at school, so that, and of course the nurses, so that everybody is on the same page as far as what we are doing. So jump ahead a couple. We have a really similar from the REAP manual. This is the return to sports strategy. The document we use is very similar. We just have some extra stuff written on here. So again, we've already been through our initial assessment. If we see red flags that have progressed over the past couple of days after they saw their primary care, then we're going to refer to the emergency room. Or we've determined and they've been sent over because they had concussion without any more sinister pathology. Pretty much you can see that all the activities, it just requires about 24 hours of no symptoms or symptoms improving to really move on to the next step. So like Dr. Rubeor said, you might be out of school for a day or two, but we expect people to go back to school within that week, or within a couple days. So if they can go to school, it's, and they do a half day and they do pretty well, no increase in symptoms, then we might, see how they feel the next day, go good 24 hours, and then we might jump up to a full day of school. And again, that's with modifications. So that could be with, moving the seat or no exams or no tests or no homework, because when they're home, we want them to take some cognitive rest. So there will be some modifications kind of mixed in there, but really you can see that as long as they don't have any increase in symptoms with each step, then we move on to the next step. We have a little side note over here. If symptoms persist beyond 7 to 10 days, then we actually go into a little bit of a different protocol, more like post-concussion syndrome protocol, because we expect pretty much their symptoms to kind of be gone at 7 to 10 days. If they're not, then we start to get a little bit more aggressive with our treatment and progress their activity a little bit more. But we do expect, pretty quickly that people are feeling a lot better. Even though, we always tell them, even though you may feel like you're doing really well, sometimes when people feel like they're really doing well, they may say, yeah, I'm great. I don't need you anymore. I'm just going to maybe not show up to my appointment, and I'm going to start going back to sports. But they're still very vulnerable at that point. So the way we look at it is, 1 or 2 weeks in, people are still very vulnerable for having another impact and causing further damage. So the research that we follow shows that the brain is not really fully back to its normal metabolic state until about 22 to 30 days. So, I tell these patients at the least, we're going to have to be out for, 3 to 4 weeks before we get back to contact sport. And I do not want to scare them, but I do educate them on the repercussions of what would be a second impact syndrome, because it's really important at that point. So again, even if they feel better, they need to continue to come. We need to continue to make sure we progress and we pace properly back to the prior level. And just the other half of this algorithm here. So if they pass the treadmill test and they're now at a full day of school with no symptoms, then we can go into non-contact and light sports-specific activities. So starting to do some soccer drills and dribbling, running up and down the field, maybe more sprints and things like that, cone drills, ladder drills, all that type of stuff. We will do that in the clinic to help them out and give them the confidence to do that, because some people might be afraid. but also instruct them to do it at home and still avoiding, potential contact. If they do well with that, again, it continues greater than 24 hours with no symptoms, then we progress into higher intensity non-contact sport specific. Also maybe progressing some intensity on weight training, resistance training. And all along the way here, we are continuing to make sure that our cervical spine and our vestibular systems are being addressed. So pretty much most of our focus during treatment is on the neck and the vestibular system. All of this stuff is part of our education, as the patient comes in and as they're leaving, and we're talking to them every day. Every visit is a new step. So we're educating them on what to do next and what's next, down the road. And then lastly, the last physical exertion test that we do is the Chicago Blackhawk test. It is the treadmill test is actually pretty intense, maybe not for the younger athlete, but it can be for the older athlete or somebody that might be more sedentary. So sometimes we don't really have to do that with somebody who is sedentary. But with a young athlete, we're doing the Chicago Blackhawks test before they get back to contact sport. And it is pretty intense. If they pass that test, then we say they can return to full contact practice, make sure they feel okay there, and they have to at least do a practice and feel fine before we move them on to a game, because games can always be a little bit more intense. One thing that you might see on here is some talk about baseline testing. So it's at the beginning off of our initial assessment. So if we have had the opportunity, one thing we provide is baseline testing, which doesn't just include the impact test, but it includes other cognitive tests, balance, reaction speed. So if I take in one athlete, it would take me about a half hour to run a baseline test on them. And then they on top of that would do the impact test. So if somebody comes to us with a possible concussion, then we will, if we have their baseline testing, then we will retest and we'll see if that, where their performance is now compared to before. So if they have no change in any of those symptoms in any of those tests or performance, then we, would assume that they don't have a concussion. We have we're fortunate enough to have that baseline test. And that's, of course, if they don't have any other symptoms. If they have any other symptoms, then it automatically puts them into a concussion. But if they just had a hard hit and they're unsure and they want to come in and get checked out, then we have that. So that's what you see at the end here too, is we retest baseline tests at the end and see where they're at with that. Most people, I would say, do not have the baseline testing. So again, very similar here, just some more detail on our algorithm that we use. But if you read the fine print here, it's, an initial period of 48 hours of relative rest, and then really at least 24 hours between each step. So it's nice and laid out there. This is just the Chicago Blackhawk test. So again, the initial treadmill test is all walking on the treadmill, with the incline being the toughest component. The Chicago Blackhawks test includes a similar, very intense, progressive ride on a stationary bike. And then we do different things like changing levels, jumping, lateral hops, burpees, and things like that. And this actually can take me close to an hour to do this whole test. So it's very intense. People are very fatigued after that. And as Dr. Rubeor talked about, if people are struggling, then I try to, as quickly as possible, get them into the right direction. So speech language pathology, neurology, neuropsych, neuro-ophthalmology, cognitive behavioral therapy. I always kind of connect with Dr. Rubeor first and say, hey, patient's struggling with this. What do you think about a referral here or there? And again, take that team approach and get them in the right direction. And I hate waiting too long. Because again, things can spiral and out of control and take a while. And that is it right at 2:00, up to 2:01. All right, but that's all I have. So yeah, definitely open to questions. And I'm going to stop sharing.
Okay, well, thank you, Dr. Rubeor and Dr. Garlick, for a lot of information. I always get excited because, it does take a village. And to get everybody and get this culture of communication going among all the different areas in the school is near and dear to my heart. as a former middle school teacher. I still teach up at Rhode Island College and as an adjunct in the LED department. So I go and try to give my pre-service teachers lots of information about the REAP. And I've also worked with RISAS as well to talk about how the concussion can exacerbate pre-existing conditions, whether they be anxiety or depression or ADHD. So it's a very complicated thing to have is a concussion. But before moving on to the Q&As, I just wanted to mention a couple of things, reminding participants to put questions in the chat box while I'm chatting here. And that their evaluation goes to Richard at biari.org, so we can comply with the CEUs and get that done. And school nurses, I want to also put a plug in for our June 9th webinar, which talks a little bit more of the customization of REAP for Rhode Island. It will also talk about the Department of Health has a TACT subscription. So a TACT is a teacher acute concussion tool. And what that is Karen McAvoy, who did the REAP, also did Get Schooled on Concussions. So it's really important. We want to make sure that teachers get this information as well. So we use all those prongs and all those colors of the REAP. And so what would be is the school guidance counselors also are getting this information. So between the school nurse and the school guidance counselors, if a teacher has a student returning to their classroom post-concussion, they can go onto the site. We'll give you the site at the June 9th one, the site and the password, and they put in some information. They fill out maybe 8 questions, and it's not about the student, it's about their teaching. So if you're a high school teacher who does science, that it's hands-on. And then what happens after that for the next 3 weeks, which is, very important time, you said, for that first month after concussion, they're going to get emails getting sent directly into their inbox about any kind of concussion accommodations and adjustments that they could make, because students, whether it's processing speed or memory, they'll get little tip sheets for that. So we're really, really excited about that coming to Rhode Island. So I don't know what I said, teacher compute, that's the TACT protocol that will be on June 9th. So I'm also looking at some of the chat right here. Let's see if anyone has any questions. Referring people to speech therapists. Oh, this is from Lucia Washington. Explain that SLPs are also treat cognitive skills. The general public does not know that, but when folks are referred to me, they say, but I can't speak. Thank you, Lucia. Richard's email address is in there for people who need to talk to Richard about CEUs. And Donna will make sure that you have a link to complete the survey. What we actually sent out to you with the link, we added the attachments of the conference booklet and also the evaluation form, but we can send that out again. Okay. It will take a couple of weeks for us to get the recording up onto our YouTube channel because we go through and we edit it. Copies of the slide deck. I know we will have it as a recording. That's entirely up to John and Amity. I don't know if you wanted to answer that, if the slide deck will be available.
Yeah, I'm fine with that. I can email it to you, I guess. And
you can email it to me, and then maybe we can make it available when we put the recording up. It'd probably be best to, if we're going to do that, we'll put the slide deck up along with it, so it's all done in one spot.
Perfect. I'll send mine too then.
Thank you so much. See, invitation, registration information, any registration information and CEU information that you can contact us afterwards. You can contact myself or Richard Muto in the office. Okay. Well, I think that's it. I don't see any additional questions. Does anyone have any questions? We have a few more moments. I have a question, if you don't mind. How do you interact with schools? Because, interestingly enough, in all of this stuff with Return to Learn, you always hear about a patient liaison, and I'm like, that seems like a unicorn to me. And I know that there are you have some people that might be working as a patient liaison, or how does that work? How do you interface with schools normally?
I can talk first, John, since you're still on mute. I think that oftentimes I talk to the school nurse. I feel like that's my primary contact. I have sometimes talked to the school psychologist if I have a student involved with the school psychologist as well. But I do try to incorporate the team. And so I also encourage the family to talk to the school nurse so that we're all on the same page. So I really try to make sure that all of us are talking, but I really appreciate talking to the school nurse.
Right. Yeah. Well, I agree. I totally agree. So we're actually trying to make sure that as the more people get informed, the more we take off their plate, but they might be just the contact person to get to the teacher. And we also want to get more information out with the REAP manual, because the REAP manual is really just an overview. We want to get a little more deeply into that, but we want to make sure that the REAP manual gets into emergency departments and maybe pediatricians, because we're finding sometimes there's a little bit of a breakdown. And when you talk about the concussion, the return to play laws, I mean, Paris was supposed to happen last year, Paris of 2020, they were supposed to update those. They're not, from what I understand, they're supposed to be updating it maybe this year. But we do get updated information as we move along. We also want to get the REAP manual translated into Spanish as soon as we can. But we're just, right now we have that really good overview that we can all, it's very digestible for parents. And it would be lovely if parents could access this when they take their child in to get medical services. So at least they have something to advocate for themselves when they go back to the schools. So anything I don't see. Okay, we'll send out the email link for the evaluations right away. We'll just resend them all out again. Okay. So I think that's, it was very, very informative. Thank you so much. I feel so relieved that we have people on our side that know the importance of that synergistic effect of everyone working together. It was very informative, and I look forward to working with you both in the future. Deborah, did you want to say some parting words?
Just to say thank you to Amity and to John. The presentation was really interesting, and I'm sure everyone enjoyed it as much as I did. So thank you so much for your time and your expertise. We're very grateful.
If anyone wants to get in touch with me, now that we're going back into schools, I'm happy. I've given faculty meeting talks. I've gone and talked with athletic trainers. I've talked with athletic directors. I've talked with teams themselves and coaches. So I'm available. So you can get in touch with me at Doreen@biari.org. That's all for today. I thank you for your time and your attendance.
See you on June 9th.
Yes, well, hopefully we'll see you on the 9th. Take care, everyone. Stay well.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Thank you.